Thanks very much, Dudley, and good morning, good afternoon, colleagues. Thank you for the opportunity to discuss our work on alcohol control investment cases together with my colleague, Rekve. Next slide, please. So as many of you know, the Global Safer Initiative was established in 2018 with the aim of supporting countries to strengthen implementation of the 5 alcohol control measures that you see here listed on the left of the slide. The Safer Initiative is a partnership of international organisations as well as global civil society organisations listed on the right. And we have 3 work streams, technical assistance, country partnerships and capacity building, as well as advocacy and communication and fundraising efforts. Next slide, please. So this slide shows a typical workflow for our country partnerships. And some key outputs include landscape reports that analyse the political economy of alcohol control policy reform, similar in many ways to institutional and contextual analyses. They also include joint missions, which help prioritise safer interventions in accordance with national priorities, and 24-month multi-sectoral roadmaps, which typically include an alcohol control investment case as one of the actions over that 2-year period. Next slide, please. So moving to our work now at the global level, this slide outlines our work so far and future planned work to develop an alcohol control investment case methodology. We're working with Anna and her team, and we developed what's now an advanced draft methodology. And we're now moving to cross-validate the One Health tool with the more data-intensive Sheffield modelling tool. So pending the outcomes of this cross-validation exercise, we plan to make any adjustments necessary to the One Health tool and then incorporate that into this methodology, the draft. We then plan to pilot the methodology in our safer partner countries, Nepal and Uganda. And then based on the outcomes and feedback from those country partnerships, as well as our broader network of collaborators, we have the goal of finalising the methodology and publishing it later this year, hopefully over the summer. Next slide, please. So our overall goal in the context of SAFER is to recommend and to provide guidance on a standard and alcohol-specific approach to investment cases that's feasible in countries with limited data and that will be able to withstand inevitable scrutiny from industry and from other stakeholders. So as part of this process, the One Health tool emerged as a leading candidate. As has been referenced today, the estimates come preloaded in many cases, and it's already familiar to many national users through NCD and mental health investment cases. But it has some deficiencies in relation to alcohol. For example, some important diseases and injuries are not part of the tool thus far. So this led us to the validation exercise, which I've described, and the Sheffield model was identified as a gold standard comparative model because it was, of course, developed for alcohol-specific policy analysis, and it's a lifetime modelling, which enables a more complete comparison. So we're working now to run data from select countries and then adjust the One Health tool depending on the outcome of this exercise. As I mentioned, we also have a process for eliciting feedback, including pilots in Uganda and Nepal. Next slide, please. So this slide outlines some of our key learnings so far. So one, of course, is that the lack of a less data-intensive and alcohol-specific modelling tool is a barrier for some particularly low and middle-income countries wishing to undertake investment cases. Secondly, there is some work going on in alcohol control investment cases, of course, which is a good start, but there isn't a standardized approach so far. So this is something we plan to offer to countries, and we think this will promote efficiency in terms of the technical guidance and assistance that we can offer. And although national investment cases are the ultimate priority, this more standardized approach will allow for cross-country comparisons as more countries adopt this approach going forward. As I've referenced, we know that investment cases will be scrutinised. So in particular, the replicability of our methodology is a good way forward to help ensure scientific soundness and response to the type of criticisms that we can expect. As I think Anna mentioned this morning, investment cases sometimes require lengthy approval processes through multiple layers of government. So in the SAFER context, one of the lessons has been to separate the investment cases, which are of course complementary to the overall SAFER process. But in case there are delays, we want to make sure they're treated separately so that any approval delays don't delay our overall roadmap implementation. And lastly, as I referenced, there is some overlap between our SAFER analysis and landscape reports and the typical ICA approach. So we are planning to integrate that ICA into our landscape reports to make sure that that's as streamlined as possible and those two analyses are consistent going forward. So I'll stop here and turn it over to Dag if he has anything to add. Thank you.
Yeah, thank you very much, Sarah. And just a couple of comments to highlight what Sarah pointed out. That is especially that we integrate the ICA into the SAFER landscape report, because SAFER is then focusing on implementation, while the investment case is more scientific advocacy for the interventions and for the roadmap that is created based on what is seen as the feasibility and a phased out in different interventions. And the investment case should come in as an advocacy tool in helping that. And I think it's also important to highlight that we are wanting to standardize methodology for alcohol, because we know everyone that the input data is, whether you use the global burden of disease or you use the global status report 2019 or the new SDG 3.5 report data, that might produce considerable different numbers. So we want to, in a way, secure that we don't have 4 or 5 different methodologies that then can be tested on the same country and have so big difference in the numbers that it can easily be, refused the whole exercise. So that is something we are trying to do also, and we know also that the One Health tool doesn't include all the alcohol attributable conditions in it, and so you need to plug in your own data there, and so that is why we are really careful with now doing this, and we want everyone to be involved, and hopefully we can come together to a standardized methodology for alcohol, which of course will have to be adapted to the different country settings. And finally, what I would like to say also is that originally we had idea of an investment case plus, which would include the revenue generation from excise taxes, but due to many reasons that was not included, and partly because of the complexity. We are still open for it, but at the same time we are extremely cautious with using excise taxes as revenue generation as a huge advocate for implementing the interventions, because it creates also a conflict of interest in the government, for example, for availability restrictions and marketing restrictions and other sides of it, which we have seen in Uganda, where we are now implementing SAFER. We see the huge revenues that it is contributing to Uganda economy is really a barrier for advocating for implementation of the SAFER interventions, etc. So that's why we really focus on having a holistic focus on alcohol in the investment cases and trying to get everyone who is then dealing with alcohol, specific alcohol control investment cases to join in this effort, and hopefully we can agree on a joint methodology in the end. Thank you.
Thanks, Dak and Sarah. Super. This is exciting work that's certainly going to be a benefit from the test between the standard One Health tool and the Sheffield model, and we're happy to be part of it.